So my pleasure this morning to introduce the first of our speakers, Dr. Kirsten Shaw, and then Dr. Ekman will introduce the next speaker. So Kirsten is a senior fellow, the last of our senior fellows to present. She's a native of Cambridge, Minnesota, went to California Lutheran for undergrad, returned to the University of Minnesota for med school. She was a resident and chief resident here at Abbott. And for a while, I thought we were going to be able to recruit her to join Cambridge as a badly needed primary care doc, but we got something better as she joined our cardiology fellowship. She has incredible energy and enthusiasm and makes everybody around her a little happier when she walks in with her positivity. So, but she has done a tremendous amount during her fellowship. Well, she's echo boarded, she's nuke boarded. She developed an app to help people learn how to read echoes that's available online. She developed a mentorship program for underserved high school or underrepresented high school students that are interested in healthcare. She has a line of research looking at the intersection of popular media and public health. Her paper in JHA on the depiction of heart attack in popular film generated a ton of popular media attention. And for those of you that were expecting that talk, that's where hopefully we'll get that in another day because she's just going to talk about her work on the aorta. So she developed as a resident an interest similar to mine as far as how to improve the care of people with incidentally detected aortic dilation on imaging, and she's going to kind of work through that with us today, and has presented preliminary fashion when we have a quality improvement project we're going to release. We had hoped to recruit her here, but unfortunately she's going to join a practice in Santa Maria, California. So thanks for being here.
Thanks, Dr. Harris. All right. Awesome. Good morning. This mic is good. Okay, today I'm going to talk about adherence to imaging follow-up in thoracic aortic disease. And as Dr. Harris said, this is a project I've been working on with him here at MHI. But the idea sort of started when I was a second or third year internal medicine resident. So I'm going to talk about that smaller project that I did first as a resident, which sort of built up to kind of the more exciting, larger scale, more impactful stuff that we're doing here at MHI, which I'll talk about at the end. And so essentially, whenever I saw annual physicals or Medicare wellness patients in my medicine resident clinic, every once in a while, every couple of weeks, I would get what I thought was the most dreaded echo report, which is maybe a little bit surprising of what it was, but it was this. And the reason that I hated getting this in the echo report was because I didn't understand. I hadn't read the guidelines. I didn't know about the tools we have, like Biagi data, things like that. I didn't understand why a 3.8 was significant in some of my patients and not in others. I didn't understand how to talk to my patients about what this meant for them. And then I didn't understand how we really should be following this up. And then whenever I would ask my co-residents or my attendings sort of, how do you follow these barely dilated aortas? How do you manage these? The answers I got were sort of a variety pack of things. There was, Kirsten, this patient's in DKA, we're sending them to the emergency room. I think Dr. Holbrook said that. We'll worry about their 3.7 aorta another day. The other answers I got were things like, it's not that big yet. We can wait. We'll keep an eye on it. What does the patient want to do? And then my personal favorite was this one. Called Dr. Harris, which I did and still do. But I did realize that at some point I had to figure out how to manage this disease process on my own. And that started with reading the guidelines and figuring out just how good or bad we were at following up these aortas, because it did seem like very frequently we kind of punted the follow-up imaging because so many other active issues are going on and these aortas are asymptomatic right at this size. So this prompted sort of this first retrospective study I did looking at this within just our clinic patient. And I told my staff, I want to look at just the last 200 patients that walked in the door. I want to see how many of them have a dilated aorta on any of their recent imaging. We looked at CT chest, CTCA, or CMR. And then if they had a dilated aorta, I wanted to see if they were up to date on their imaging follow-up for that. So of the whole group of 200, the aortas were between 3.5 and 4.5 centimeters. 30 of them had a dilated aorta on one of those imaging studies. And of the whole group, it was about 50% females to males, and the ages were 18 to 95. In our dilated aorta group, 5 females, 25 men, and a little bit older age, which makes sense. So then looking at how many of these people had appropriate surveillance imaging follow-up, 63%, 19 of the 30 were overdue for surveillance imaging, which is more than I expected. And if you broke it down, this is quantifying them by risk by the aortic height index, by that Zafar study from 2018. You can see, here we go. Most of them were low risk, 15 of the 19, but 4 of them were in that moderate risk category, and 2 of the 4 hadn't had a follow-up study for like 5 or 6 years. So we did also message providers too to help expedite that follow-up. But then I looked at the problem list for these folks, because in our resident clinic, we're pretty good at keeping the problem list updated. If there's an active problem or something we're following, we put that on the problem list, because you pass your patients down when you graduate and to make it easy for the subsequent residents coming through. And only 13% of these people had their aorta listed in their problem list. And then I was curious how often this is found inpatient versus outpatient, incidentally usually. So 43% of people, theirs was incidentally found on an outpatient study, gotten for some other reason, and 30% inpatient. A couple were purposefully screened because of a family history. So I plotted these people on kind of a modified table I made from that Zafar paper. You can see just our couple of moderate risk people on here. And so the results were kind of cool, and we presented it at Mayo and Yale's surgical conference and then ESC, and the feedback was all really good. Mayo said, great potential for quality improvement. We won their poster conference. Yale said, turn that abstract into a paper and turn that paper into a grant, which I haven't figured out how to do that yet. ESC said, it's great, but bigger, do more on a larger scale, use your whole institution, which is foreshadowing for what is to come here now soon. Okay. So briefly, I know we all know the new thoracic aortic guidelines just came out in 2022. One of the things I want to point out from this, which is new in these guidelines compared to the 2010 guidelines, because it's relevant for a little bit later in our talk, is that thoracic aortic dilation in these guidelines now have a definition of 4 to 4.4, whereas an aneurysm is now defined as 4.5 or greater. And this is interesting if you dive into people's opinions on this, because there are a lot of pros and cons and a lot of commentary on this stuff. So the pros being this enhances our communication. We now know a threshold cutoff for what an aneurysm means, and aligns better with our surgical guidelines. If we're replacing an aorta in some of these people, it should probably be labeled as an aneurysm at that point. The cons being that 4.0 is low to label as a dilation. That's a normal aorta in a lot of our population. And then it can be alarming to patients to see really any of these words, dilation, or I think especially aneurysm, when they get their echo report now before we are able to talk to them about what that means, and can be a bit alarming. So my fellow brain, my question was, well, why do we have to pick just a number threshold for aneurysm for the aorta? How come we don't use the definition that we use for our other aneurysmal vessels? Because for a normal vessel with diameter of X, we call that an aneurysm once it reaches 1.5 times or greater the vessel size that we expect for that diameter. So why don't we do that for the aorta? And so the main reason is we can do a thought experiment if that works for our aortic root. So in a standard, like 40-year-old man who has an average root diameter of 3.5 or 3.6, if we waited for his aortic root to get to 1.5 times or greater its size, we'd be looking at a 5.2 centimeter aorta, which would fit into a higher risk category much earlier. We would want to be labeling this aorta as an aneurysm probably before that, because he might even qualify for intervention depending on comorbid conditions. So 4.5, we have to pick a threshold for the aorta. And 4.5 is it, based on a couple of studies, 2 main ones I want to just mention briefly. This first one by Borger, he looked at 200 patients with bicuspid aortic valves, and none of these people had their aorta intervened upon, they just had their AVR. You can see that 11% of them had a moderately dilated aorta at baseline. They followed these people for 10 to 15 years, which included 98% of the population they followed. And that group with the 4.5 to 4.9 centimeter aorta had significantly increased risk of dissection or sudden death compared to the diameters lower than that. You can see that represented here, that this group, this bottom line here, is that 4.5 to 4.9 group, and their 10 to 15 year freedom from acute complications was much lower than the other groups. And then Peruturi plotted a distribution curve of ascending aortic size, and he looked at 3,500 patients from a MESA community database using this sort of form up here to calculate these things. And basically what he found was, compared to a normal aortic size, which he called 3.4 or less, the group that had a 4 to 4.4 centimeter aorta had an 89-fold increased risk, and the group that had a 4.5 or greater aortic size had a 6,000-fold increased risk. And I'm sure you've all seen that chart, but just showing that that 4.5 is kind of a size where our risk goes up, and these are relative risks, of course. So that's fine. So 4.5 is our aneurysm size, but all these diameter thresholds are really built for people who are within 1 to 2 standard deviations of the mean with their height or body size or both. And so when we have people that are significantly taller or shorter than that, we have to adjust our thresholds. We do that with indexing. And so there's 4 main ways that we index, and I want to talk about these briefly too. Z-score is kind of the first one I want to mention. This is, of course, how we say, our patient's aortic size is X number of standard deviations away from the population mean aortic size. So a Z-score of 0 is the population mean, and the further away our patient's Z-score is from 0, the greater their magnitude of deviation from the mean, basically. So Z-score, when we're calculating that got in a little funny with formatting, but basically we take our patient's aortic size minus the population mean divided by our standard deviation. So easy, perfect. The thing is, before we plug our patient's numbers into a calculator for a Z-score, some stuff has to happen sort of behind the scenes. That Z-score calculator is acquiring a population or a cohort of people with their aortic size. They're calculating their BSA and forming like a scatter plot of that data from which they make their nomogram, and then we calculate our Z-score from that. So this works very well for pediatric populations because kids are kind of rapidly growing and we understand what a pathological change in a Z-score is in that population. It is a little bit more challenging in adult populations for a couple of reasons. The main one is variability in that population we're using to create that scatter plot and that nomogram. Those populations can be various sample sizes and represent various different groups. And so always when we're using an online Z-score calculator, always looking at what population was used to build that Z-score, because a lot of them are based on an age range sample of 0 to 17 because many are made for pediatrics. The other challenge with the Z-score is the BSA calculation inconsistency, just because there's 14 plus different ways to calculate a BSA. The most common one is actually Haycock, which was only built on a sample size of 81 people, interestingly. So depending on what BSA calculator your Z-score is using and which one you're using in clinic and which one the next provider is using when they calculate a subsequent Z-score, we can get changes that are pretty marked in our Z-score just based on which BSA calculator we're using. And finally, we have limited data on what a normal adult aorta does in terms of their Z-score over the decades of life for just a normal aorta, and then limited outcome data in acute aortic disease for a Z-score. So all of that to say, we don't use that as our indexing modality really here at MHI. More often in adult cardiology, we use the size index or the height index. And the size index really came from this paper by Davies looking at 400 patients. And basically, he found that using a aortic size index to the patient's BSA was more predictive of rupture, dissection, or death than just using the diameter of their aorta all by itself. And so he risk-stratified people into sort of 3 groups based on this. And then years later, Zafar in 2018 said, on the premise of why would your weight affect your aorta as much more than just your height? So he looked at the height index alone, just indexing to height. It's easier to calculate than using that BSA for the reasons that we just talked about too with BSA calculators. And when he looked at 780 patients, he compared the height to the size index and found that the height index really worked just as well as the size index. If you look at the concordance indexes on these studies, you'll see that the BSA-based index is a little bit noisier. It's just a little bit less well coordinated than the height index, and which is likely because our weight can fluctuate so much from year to year or day to day even. So the height index based on a genetically predetermined thing like your height probably is better correlated with your true aortic size. So this is the one we tend to use here. Again, easier to calculate as well. And we split people into these 4 sort of risk categories with a height index of greater than 2.43, really bringing you into a higher risk group that we like to see those patients in our own clinic often. Okay, cross-sectional area to height, what we use on CT and CMR, where we actually are measuring the area, and we use that threshold of greater than or equal to 10 centimeters squared per meter for that. Okay, all of that to say, we've got that in the back of our heads. Now we're going to talk about what we've done here at MHI. So this is preliminary data. We're working on our manuscript right now for this. But we wanted to look at how well we were doing within Allina MHI at following up these thoracic aortic aneurysms and dilations. So we looked at a population where they had their first aneurysm or dilated aorta visualized on an echo. So we weren't using anything found on a CTCA for the first time or MRI. So it was just echo-based first diagnoses for the 5-year period of 2018 to 2023. And then we looked at the timeliness of follow-up imaging with echo, cardiac CT, or cardiac MRI, and then looked at a couple other factors here. So the population ended up being 21,000 people, 15% female, 85% male. Comorbidities are pretty unsurprising. Hypertension is the most common comorbid condition, which makes sense. Reduced DF and heart failure in about half of the population, and then moderate valve disease in about 13%. And what we found was there was only 43% adherence in following up these aortas by our guideline recommendations. In a perfect world, you would have a follow-up imaging study of either a CT, MRI, or echo within 12 months. We gave these folks 18 months to get in for scheduling reasons or whatever else. We gave them a little window there. But so only 43% adherence to follow-up imaging. The majority of the people who adhered were in that older age group of over 70. And then in the non-adherence group, the majority were just a little bit younger. But interestingly, if you looked at what percent of each age bracket adhered, that less than 50 age group, 64% of them didn't adhere to follow-up. So it was more common in our younger population, it seems, arguably maybe the people you're more worried about. And for men and women, pretty similar adherence between the two. When we looked at adherence by ordering specialty, if cardiology or cardiovascular surgery ordered your echo, you had a 48% likelihood of getting a follow-up study appropriately. But if another specialty provider ordered your echo, that dropped down to 39%. And if we look at who's ordering of the 21,000 echoes, who's ordering these echocardiograms, cardiology and CV surgery are ordering about 38% of them, but the leader is primary care is ordering a lot of these echoes, finding these incidental findings of dilated aortas. Just to look at the other breakdown here, because it's interesting, kind of the inpatient medicine teams are leading next. Neurology and emergency medicine, hem-onc and pulm, ID and nephro, and then there's some GI doctor running around. He's ordered like 8 echoes. So if anyone knows who this is, I'm really curious about that. But so that's our main group, our main cohort. So then we wanted to do a subgroup study and look at what about the people who don't have a cardiomyopathy, they've never had an MI, they don't have a reduced DF, and they don't have moderate or worse valve disease. What if we look at just those people who don't have another reason that they may just be getting another echocardiogram? And so that ended up being 11,000 people, really similar proportion male to female. And again, hypertension is still the leading comorbid condition in this group. So only 34% of these folks are getting a follow-up study within that 12 to 18 month, or within that 18-month window. So even lower than our other group. That's a 66% non-adherence. That is not ideal. And if you look at this a little closer, if you remember from our first group there was 64% non-adherence in that less than 50 age group. Now in this subgroup analysis, there's 71% non-adherence in that younger age group. Again, potentially the age group that this is more of a worrisome finding, just because they're younger and don't have all these long-standing comorbid conditions. Okay, so the question is, what's next? How do we improve adherence to follow-up imaging in a pathology that's asymptomatic, incidentally found, and then most often found on an echo that was ordered by primary care or non-cardiology provider? So we have a couple ideas for this. So the first thing is some changes to the echo report that we're making, and this will all blow in, so it's not any additional work for folks. But this is just in a playground in Singo right now, but this will go live at some point in the coming weeks. But the first thing is we're labeling aortic dilation based on that Biaggi data that we use now. It's in the binder that we can flip through in the echo lab there. We're going to have that blow in as a dilated sinus or a dilated ascending aorta if it meets that greater than 2 standard deviations beyond the expected size for their age, sex, and BSA. So for this patient in this example, he has a 5 centimeter root. The upper limit of normal for his age, sex, and BSA is 4.2. And then following that, we're going to kind of change the order here, but following that, we're going to list the aortic height index is 2.89. A low risk aortic height index is less than 2.4. And then the ascending aorta as well for this gentleman with a 4.0 centimeter aorta, his upper limit of normal is 4.3. Again, all based on that Biaggi data. In addition to that, we're going to have this step 3, which is telling us for these aortic dilations, here are the follow-up recommendations that we have. This link we've made a lot shorter and prettier, so now it just says aorta management there. And basically, and this is all geared towards non-cardiologist providers who get these results, of course. But basically, if you click on that flowchart, it'll bring you to this PDF that I was able to develop with amazing feedback from Dr. Harris and lots of folks, Fraser and Dr. Bradley as well. And so this is what we've made, and it's essentially if you had a primary care doctor that you wanted to read the 4,000-page thoracic aortic guidelines, but just extract the pieces of information that you wish they could prioritize in their clinic in the primary care setting for these patients. And so I just want to show you a little bit how we've organized this. It's all, of course, guideline based. So step one is really, if you've had a dilated aorta identified, if it wasn't on an echo, obtain a complete echocardiogram, control their blood pressure, the goal being less than 130/80 for these people, start a statin if there's other evidence of atherosclerosis, and then counsel on smoking cessation, and listing some of the meds that are safe to use in this pathology, just to limit calls on that question too. And then step two, really trying to get to our higher risk population that we would like to see in our clinic earlier. So if any of these higher risk features refer to cardiology, that's any of our syndrome folks, it's our Ehlers-Danlos, our bicuspid valves, or actively pregnant patients. And then we also include in here the family history of high-risk features and then a younger age at the time of diagnosis. And then for step three, this is our follow-up flow chart to help make follow-up a little bit more clear. If you've read the guidelines, you know that the follow-up stuff, it's just not totally intuitive when you read through those, how to monitor a normal patient that doesn't have a high-risk condition associated with their dilation. So this is to kind of help make that a little bit easier. So if their aorta is greater than 4.4, they're at that 4.5 mark, now defined as an aneurysm, a little bit higher risk. Those are the folks, or their height index is greater than 2.4, that should be followed in our cardiology clinic. If it's less than 4.4, repeating an echo in 12 months is a very reasonable first step of follow-up for these people. If their rate of growth is acceptable, which we index down here, and if their aorta still measures less than 4.4, annual echo monitoring going forward. But once they cross over into one of those other features where we would like to see them, if it gets greater than 4.5 or their rate of growth is fast, which is rare but can happen, or if their height index gets above 2.4, then we would want to see those folks in our clinic. And then just to have an additional tool here, I made the stop phrase, which just includes a drop-down menu of all those things where if any of the following refer to cardiology, and then reminding folks to just kind of compare their aorta measures this now. Previously it was this, and kind of helping people be aware of that rate of growth change. And then reminders to look at the statin, smoking, and blood pressure as well. Okay, so that is that retrospective analysis, which we have done kind of in terms of our next steps. We're implementing these echo report changes. We've got the algorithm from PCPs kind of inlaid into that echo report to help follow-up be a little bit easier to access our recommendations on that. We're presenting to a couple primary care groups, including AIMA, in the coming weeks here. And then after these changes are sort of live, we're going to do a prospective study and see if adherence improves over the next several years here, and see if these changes make a difference. I do think that adherence will improve quite a bit with these changes, just for two main reasons. One, just having the algorithm sort of easily linked and easily accessible in the echo report itself. And then two, I think the way the echo report now blows in that Biagi data, I think will report a lot less 3.8, 4.0 centimeters as being dilated when they're an expected deviation from the mean in these people. Okay, so I just want to end with this. As a first-year fellow kind of coming in, I knew that aortic disease management required a multidisciplinary collaboration, and I kind of thought that looked like this, cardiology and surgery sort of talking to each other about things. But now 3 years into this, I've realized that it doesn't look like this at all. Multidisciplinary collaboration in aortic disease looks a lot more like this. You're talking to your surgeon, but you're also talking to your imagers, and you're talking to your echocardiographers and the patients and their family. And there's so many different players in this realm. So thank you, and thank you to everyone who helped build that stuff.
Not too late to change your mind about staying. Why the sex difference in your population, and what was the prevalence of aortic dilatation in the group that you looked at?
Yep, that's a good question. So the sex difference, I think this disease process is a little bit more common in men than women, but also we report a lot of 3.8 and 4.0 aortas as dilated in folks, and in men that is often, even based on our example study, that patient was 70 years old and had a PSA of 2, and that's a normal size aorta for him. So I think we're catching a lot of more normal end of the spectrum in the men than in the women. And then I don't know actually the prevalence. Dr. Harris, I don't know if you know the prevalence in general of how how many dilations of the whole population? Was that your question, Dr. Sharkey?
Yeah.
I don't know that.
Maybe like 2%.
Hi, everybody. Amy Holbrook. I'm the Associate Program Director for the Internal Medicine Residency and one of the clinic docs that worked with Kirsten in residency. And I think I was the one who was like, this is not the main priority right now in clinic. And I wanted to thank her for including our clinic when she was developing that algorithm because it's kind of targeted at us. But I know the cross-sectional stuff with MRI and CT seems really important, but that is not in the algorithm for primary care. Should we always be doing echoes? Is there a point where we should be ordering CTs for this? Or
Yeah. That's a really good question. Yep. So we talked about including a cross-sectional imaging recommendation in this algorithm, and ultimately decided not to, just because if every one of those 3.8 or 4.0 aortas got a CT, that's not actually an appropriate use of our cross-sectional imaging for that aorta, which very possibly could be normal or has been stable for a really long time and at 4. So we don't have that recommendation in here. Once they get to us at sort of that 4.5 time, a lot of the time that's when we're starting to counsel on like weightlifting restrictions and avoiding collision sports and doing the cross-sectional imaging to look at the rest of the arch and vessels and stuff. And so the other population that we often cross-sectionally image earlier are some of these other higher risk folks that we're also hoping to get into our clinic earlier. So yes, good question. To answer it, yeah, not all 4.0s need cross-sectional imaging, and it sort of depends on so many different factors, but including their other comorbid conditions and risks and rate of growth and stuff like that.
so we can make it your problem, not our problem.
I think that's right.
So Mike Downey, second year fellow. First of all, very frustrating to watch this presentation. See you setting the bar so high. Having to do this next year. Is there any utility, do you think, in just automating the rate of growth as well in single and having, because it seems like that's something that the reports could just pull and the computer could automate. 1 year ago was this, 2 years ago was this, rate of growth is X, so that.
I've never thought about that one time. That's a really good question. It's so rare that there's a significant rate of growth so fast, but Dr. Harris, do you have a thought on that? That seems like that would be great to have in there, but I don't know.
Yeah, we're about to switch our echo recording system, so that may be a little problematic, but it's a great idea. And we just published a paper looking at, with one of the other residents here, the rate of growth for these dilated aortas is 0.1 millimeter per year. So, I mean, obviously some people grow, but it's not too often, but I think it's a great point.
You're talking about functional data systems, and these are semi-functional data systems, right? So it's impressive that we're able to, within the echo report, go to the table, pull the data necessary within that report. That would require the data structure understanding where to look in the prior report, which is probably a bridge too far at this point, but not an unreasonable question at all.
Hi, Kirsten. Great talk. One comment about that. I, in a previous residency project of my own, was trying to look at rate of growth stuff in big population data for aortas. The big trouble we had is there is variability. And so you might have a scan that tells you, oh, it's 3.8. And then 12 months later, you have a scan that says it's 3.6. And 12 months later, you have a scan that says it's 3.9. And then how do you rectify what that looks like? So it's a great question. It's a really great question that I've spent far too long to sort out in my own mind. But yes, that's sort of the trouble that we ran into, especially in big data sets where it's hard to account for that variability. But my other sort of question comment from a surgeon perspective is, and maybe Rizwan can corroborate this, but we get referrals, patient comes to our clinic with an echo, all they've had is echo or echo, that says your aorta is 4.4. And the very first thing I say is, this is not gold standard imaging for the aorta and size, and so I order a CT. And so I think your point is great about, primary care not having to worry about that and just sort of getting referrals on for those that seem to be approaching or in that area. But have you thought about trying to figure out in the patients on echo that say their aorta is 4.0 to 4.5, does that corroborate with the CT measurement? Because I find oftentimes it's not the same. I don't know, this one.
I agree.
Yeah.
It's not the same.
It would be interesting to see in that
No,
population.
but most of the data has been validated with that.
I know, but like in clinical practice, I don't believe echo reports unless it's quite large. I mean, unless it's obvious that it is.
Yeah, there's, I mean, just to speak to that, I'll get a message from a primary care doc because the patient is, kind of freaked out by the feeling that the aorta's bigger, but there's a lot of measurement error. The CT or MRI will kind of standardize, but there's a lot of variability in those techniques too, depending on who the reader is. You see that all the time.
Great, thank you guys so much.
All right, good morning. Well, it is my pleasure to introduce our next speaker. Let's see if we can get this talk switched over here. Got it. I do know how to run PowerPoint, but no. All right, thank you, everybody. So it is my pleasure. This is a tough act to follow, but I know our fellow Dr. Masih is going to be up for it. Dr. Rohit Masih is currently one of the advanced, or our only this year, Advanced Heart Failure and Transplant Cardiology Fellow. He did his internal medicine residency at the Lehigh Valley Hospital in Pennsylvania. Prior to that, or prior to his time here with us, he worked as a hospitalist in Hartford, Connecticut, where he was very involved in the management of patients with cardiovascular disease. While in Hartford, he had research projects looking at outcomes of patients undergoing TAVR, including those with concurrent coronary disease, low nutritional index, and TAVR in patients with cardiogenic shock, which he has presented at multiple meetings, including TCT, TVT, ACC, HFSA annual meetings. When he's not at the hospital, rare occurrence, he's a devoted husband and father and loves to travel, and is delighted that his fellowship brought him to Minnesota for the first time, which he's been very much enjoying. So I am very pleased to introduce Dr. Masih, who's going to present a particularly rare case. So thanks for joining us.
All right, so good morning to one and all. And I just want to echo what Dr. Downey's comments meant. It's not so much frustrating, but a little rather intimidating with such a great presentation and great work that you've been doing. So kudos to that. And so I'm going to be talking a little bit about HeartMate 3 pump thrombosis, and as the title suggests, expect the unexpected for a number of reasons. And when I was tasked with this to present here at Grand Rounds at MHI, I was kind of thinking back what could be an interesting topic to present on. And one of the things that came to mind was this case I came across a couple of months into this fellowship here in fall of this year. And the reason I picked this case was a twofold. One, to shed some light on this rare occurrence, and also to kind of go through the management of these patients and how to go about it. So with that, we'll start off with a little background. And I have no disclosures. So this is the case of a 56-year-old male with a history of coronary artery disease. He's status post PCI of the LAD, left circumflex, and the RCA, with subsequent ischemic cardiomyopathy of with an LVF of 25 to 30%, and this was complicated by cardiogenic shock. So subsequently, he underwent LVAD implantation with HeartMate 3 in February of this year, of 2024. And he really presented to the emergency department in August with complaints of shortness of breath, chest pressure, and associated weight gain. So on presentation, patient was hemodynamically stable with a MAP in the mid-60s to 70s, which is not unreasonable to see in patients that have a VAD in place, heart rate of 98 beats per minute, and afebrile. Some pertinent labs included white blood cell count of 21,000, and otherwise hemoglobin and platelet count was within normal limits. On the metabolic profile, he was noted to have a bicarb of 18 with a creatinine of 1.48 and liver function tests, which were within acceptable range. So more labs here. ProBNP was quite quite high, over 12,000, and a lactate of 2.8. And I just wanted to point out the proBNP trend. So as you can see here, not unexpectedly, after LVAD placement, you don't expect the proBNP to quite normalize, but this time it was much higher than the values they were previously, which at the highest was 4,000. This was prior to the VAD implantation. So on emergency, on presentation to the emergency department, of course, you got a troponin checked, and it was 28. Subsequent troponin kind of was rising to in the 70s now, and 6 hours later, it was 10 times the limit that it was previously and continued to rise. So that got us a little, concerned about it, and we pursued an echocardiogram which showed a HeartMate 3 at 5,800 RPMs. The cannula flow was not well visualized. However, there was no high velocity signals. It did show a severely reduced global systolic function with an estimated EF of 10 to 20% and a severely increased LV size. The internal diameter was 7.1 centimeter at that time. The RV function was reduced, and he was noted to have a trace MR and moderate TR. So, for a recap, we have a 56-year-old male post-LVAD about 6 months after LVAD who presents to the hospital with complaints of shortness of breath, chest pain, and basically signs and symptoms of decompensated heart failure. So we had our thinking caps on and thinking what could be going on. And primarily the one more striking feature in this case was the increase in LV diameter. So post-LVAD, we don't quite expect the LVEF to improve per se, but however, with LV unloading, we do expect the LV size to decrease, which was a little bit concerning in his case. So one of the top things on our mind was outflow graft obstruction of the LVAD, which we don't, see uncommonly, and so we went ahead and pursued a CT cardiac morphology to kind of evaluate further or rule that out. So this is a 4-chamber view of the inflow cannula here, and you can see here there's really no signs of obstruction in the inflow cannula on the cardiac CT in the 4-chamber view. This is a view on the CT cardiac morphology of the LV outflow graft. As you can see here, there's no really obstruction noted in the LV outflow graft to the anastomosis with the aorta. So the impression was this is the appropriately positioned HM3 or HeartMate 3 LVAD with no obstruction of the inflow cannula, and the outflow graft was widely patent. Patient was noted to have a severely reduced biventricular systolic function, and the aortic valve was oversewn and did not open. So generally speaking, patients with anything more than mild aortic insufficiency, you do want to repair the aortic valve, from what I understand, basically in some way, whether it's replacement or repair, and sometimes surgeons would do what we call oversewing. In other words, it's basically taking the tissue and stitching it together. So it's not that the aortic valve is completely shut, but rather it's restricted in the sense that it limits the degree of regurgitation that happens. So in this paper by Tang and colleagues here, which talks about aortic valve repair versus replacement associated with durable LVAD devices, you can see here the Kaplan-Meier curve, where over long-term follow-up over 3 years in patients that underwent aortic valve surgery versus the ones that didn't undergo aortic valve surgery, there was really no difference in cumulative survival over 3 years. What's interesting is that the aortic in patients that underwent the Park stitch, the freedom from AI recurrence. So in other words, the patients with that underwent the stitch, there was a higher risk or chance of aortic insufficiency recurrence over 5 years. The other thing that's highlighted in this paper is the cross-clamp time, which I think was found pretty interesting, that there's a big difference between aortic valve replacement, which is around, you see highlighted here, 50 minutes compared to aortic valve repair, which takes about cross-clamp time of 12 minutes, which was significant. And this in fact may play a part in decision-making of what to do a patient with that undergoes LVAD implantation and patients that have aortic insufficiency. So a lot of times, surgeon may choose to do a repair as opposed to a replacement in patients with, particularly with a vulnerable RV, which was thought to be the case in our patient. And I just want to shift gears a little bit here. This is the STS 2020 report, which shows the use of LVADs over the last decade from 2010 to 2019. And as you can see here, there's more axial flow pumps that were being used up until 2015, more so 2016. And then there was a shift in the choice of pumps, and mainly because there was improvement in the pumps that were designed. And one of the big factors was the centrifugal hybrid levitating rotor. And you can see here in 2019, a majority of these were HeartMate 3 to the centrifugal magnetic levitated pump as a destination therapy. And in fact, over the last 3 years of this report, 2017 to 2019, more than 50% were used for destination therapy. So some changes have been made in the previous devices, particularly in the patients from HVAD or the hardware. Initially, there was larger flow gaps to improve hemocompatibility, and there were textured blood contacting surfaces that were put in place to help improve, or I should say, improve blood flow and decrease the risk of stagnant blood flow to increase risk of thrombus. The other thing that was different from the HeartMate 2 versus the HeartMate 3 was the centrifugal flow and the magnetically levitated rotor. So this diagram, I really like this one because it really shows, this is the fully mag level flow technology pump, which has larger consistent blood flow pathways to reduce shear stress compared to the hydrodynamic bearing pump, which has narrow blood flow pathways. So put that in perspective, you have about 8 stacked red blood cells that can flow through this versus 167, which is 20 times much higher in the maglev fully levitated technology pump. This is the diagram showing HeartMate 2. You can see here the rotor and basically these so-called inlet stators that this is axial flow pump and kind of go through. The rotors have sort of blades here that kind of increase the risk of thrombus or fibrin deposition and thrombus formation within that the pump housing or the motor. This is the diagram of the HeartMate 3, where you can see the inflow cannula and basically the pump chamber and the rotor that kind of sits here. The rotor magnet is there as well as the outflow graft. And one new thing was the outflow graft bend relief. And another thing that was incorporated into this is basically notches towards on the bend relief to basically decrease shifting of this outflow graft during even speed changes or manipulation of the pump. So the outcome on this is a paper by Mera and colleagues, Momentum 3, which most of you may be familiar with, the 2-year outcomes of the magnetically levitated cardiac pump and heart failure. And this was an analysis of 366 patients and comparing the axial flow pump and the centrifugal flow pump over 2 years. So the primary endpoints in this study was basically freedom from replacement, or I should say primary endpoint was basically stroke, freedom from stroke and incidence of stroke in these patients over a number of years, and also freedom from basically reoperation or removal of the pump related to suspected or confirmed thrombosis. So, and the study did meet their primary endpoint, and which was primarily driven by absolute reduction in stroke risk by about 9%. And what's interesting is that in the centrifugal flow pump group, which was 189 patients, and the axial flow, which was 172 patients, the suspected or confirmed pump thrombosis was 1.1% in the centrifugal flow group versus 15% in the axial flow group, which was statistically significant, And there was also pump thrombosis resulting in reoperation or removal of the device in 20 or 12% of the patients in the axial flow group. So when you follow these patients over 5 years, the outcomes in fully magnetically levitated axial or versus axial flow device in the Momentum 3 randomized trial, the authors noted that the suspected or confirmed pump thrombosis events per patient years was 0.01 compared to 0.10 in the axial flow group. Also, in patients with centrifugal flow pump had a lower incidence of GI bleeding or stroke. This was a strong signal that favored basically the HeartMate 3 device and really sets the stage for that shift in device placement in these patients, as I pointed out earlier in the STS report. So in view of the LV dilatation with symptoms concerning for cardiogenic shock, a right heart catheterization was pursued to evaluate hemodynamics. As you can see here, the LVAD was at 5,800 RPMs, which gave a flow of about 2.6 liters and pulsatility index of 3.6. RA pressure was 11, RV undiastolic was 11, PA mean was 38 with a wedge pressure of 18 and a FIC calculated cardiac output of 3 liters and an index of 1.44 liters. So, suggestive of cardiogenic shock based on the right heart cath report. So the LVAD speed was ramped up to 6,000 RPMs. However, the flows remained unchanged and estimated cardiac output decreased to 2.86 and cardiac index of 1.36. And the idea of the ramp study basically is, with a certain number of RPMs or motor speed, you expect the flow to increase if you increase the RPMs. And in patients with, problem with the LVAD or in heart failure, with an increase in RPMs or speed, you expect the flow to increase, which in our case, it did not. So other parameters which you expect to also improve is decrease in filling pressures and decrease in severity of MR and LV diameter to really decrease with LV unloading with the LVAD. So this is the log files that we obtained from the patient. And I just want to point out here, it's a little bit harder to see, but the blue line here up top represents the actual motor speed. So you can see here this is dating back to August 13. So about 10 days back from the day of presentation, the motor speed is pretty constant in the 5,500, 5,800 range. And this is, you see the increase where we did the right heart cath study. But also I want to point out the motor power, which was relatively unchanged. What's striking about this or interesting is the calculated average flow, which is sort of this orange line as you follow along here. And it was more or less in the 4 liter or 4 liter plus range all throughout. And then you see a sudden drop about 3 days or even 48 hours prior to presentation to the hospital. So you notice here the flows really start to decrease around August 21st. The day of presentation was August 23rd, but you notice it drops below 4 liters. It continuously kind of decreases and then abrupt decrease the day prior to presentation, where the patient was only getting 2.5 liters of flow. So with that, with rapid decompensation of the patient during right heart catheterization, despite an increase in RPMs or an attempt to increase flow, there was concern for something wrong with the LVAD, whether it's outflow graft or something else going on, that was to be figured out. So we sent the patient for chest exploration or evaluation of the LVAD, sort of in an emergent fashion, and we did decide to cannulate for VA ECMO to support him through that. And this is what we found during the case intraoperatively. So you see the inflow cannula here, and you see distally, there is basically obstruction of flow distally. What appeared to be something like a fibrinous material, and the concern was whether this is a thrombus. So we sent the device over to the manufacturers for expert analysis, and this is sort of the inflow cannula proximal view that you can see here of the inlet inflow cannula. And distally, you can see there's basically obstruction. This is what was explanted out of the device, and you can see a really nice formation of this, quote unquote thrombus at that time. We didn't have histological pathological diagnosis, but suspected thrombus. This is the proximal view, and distally, kind of, you see the view here in a sort of like a cylinder tapering from 9 millimeters to 6 millimeters here. We sent this for further evaluation. Histologically, you see here the inflow cannula surface, there's more compact acellular protein material, and the scallop edges. This is more so towards the inflow cannula or the outer layer, and this is towards the lumen, where you see pseudo-intima remodeling in the absence of neovasculogenesis. So there was no de novo mural thrombogenesis, and you see basically large vacuoles with fibrillar to granule material. And this is a little bit different, and we'll talk about this like a little bit different from EOG or extrinsic outflow graft obstruction, where we see larger vacuoles in sort of the luminal surface of the vessel or of the thrombus. And this case here by Labrada, that was published in the Journal of Heart and Lung Transplantation, really shows the concept or the pathology related to extrinsic outflow graft obstruction. So you see here the surgical specimen and the cross section. You see the blue arrow points out to this kind of proteinaceous or material that kind of builds up between the bend relief and the outflow graft. So this bend relief pointed out with the yellow arrow and the outflow graft. And so it kind of settles in between those, and then it ultimately causes compression and thereby decreasing the flow in the outflow graft. This is a picture of something that I've learned that we're doing here over the last few years, actually. And this is, as you can see here, this is the bend relief for the outflow graft. And you notice here, there's basically fenestrations. And this is what the surgeons are doing here, basically a fenestrated outflow or bend relief for the outflow graft to decrease the risk of basically EOGO. And till date, since 2022, we have about 30 patients that have been followed over the years, and with serial CT cardiac morphologies that did not show evidence of that. And this EOGO itself is actually a recognized problem with the LVADs and particularly HeartMate 3, despite the bend relief. In fact, we've developed protocol here with surveillance imaging, serial surveillance imaging with CT cardiac morphology to be able to pick those up patients sooner rather than later. So just some learning points here with this case. It's important to be vigilant regarding this potential complications and early intervention. So if you have a patient presenting with, or LVAD patient presenting with signs or symptoms of decompensated heart failure, and particularly in patients with cardiogenic shock, it's important to be aware of this phenomenon and this potential problem, and to be able to recognize it and to be able to work through it in an expedited fashion. And we came across or learned about 2 other cases that have been published. It's not a very common phenomenon, although it is rare. However, it does exist. So particularly in patients that have an increase in LV diameter without evidence of outflow graft obstruction on imaging should raise suspicion and warrants detailed evaluation of the LVAD log files, like in our case we did. Particularly in patients with an oversewn aortic valve, one should expect rapid decompensation, and VA ECMO can be used as a bridge in these patients through HeartMate 3 exchange. So with that, I just want to share some acknowledgments for Dr. Branowitz, Dr. Ekman, Dr. Lodowicz, who was the operating surgeon for this case, Jess Boughton, our LVAD coordinator, and also our folks at Abbott for the analysis for the specimen. Thank you so much for your time, and welcome any questions.
I know we have a lot of imagers in the room that see a lot of the CTs and echoes, and so I think it may be helpful to see kind of what are some of the things we're looking for when we're worried about these patients. But just to highlight this, there have been about 30,000 HeartMate 3s put in this. We believe this is the 3rd case of this non-clot based obstruction, and it's in the pump, so the imaging, echo you can't see in the pump, CT you can't really see inside the pump, and so it's really a clinical diagnosis. So it's really, I think, highlights a lot of the physiology. You did a very nice job, Rohit. Any questions?
Is there a, that was very interesting, but is there, because of the behavior of when you increase the RPMs, the flow then increases, do you think there's a dynamic nature to the obstruction because it's tissue that with a higher RPM rate, the obstruction actually got worse? Or is that?
I'll let you answer first, then I'm happy.
Sure. So, and that's a great question. I mean, really, I think it is dynamic in the sense that it kind of builds up and then to the point where there's enough obstruction to really limit the flow. And that's what we saw in our patient in, 48 hours prior to presentation, there was a sudden decrease in flow. I'm not too sure doing the right heart catheterization if, the obstruction was there to begin with. I'm not sure if it can get any worse. I think this is just basically, with an increase in RPM, they really basically it's just suggestive of obstruction of complete flow, not enough to generate a good enough cardiac output. I don't know if that kind of answers it. I'm not sure.
I think of it analogously to like if you're doing an adenosine nuclear stress test, if you're already maximally dilated, you give adenosine, you're not going to get more flow. Here, it's kind of the flip side. You've got a certain amount of stenosis. You turn the pump up, it doesn't matter. You're not going to get more flow.
Or could the flow actually go down when?
Yeah, so I did the cath. I think it was pretty fixed, and also from what you saw, like that one image that Rohit showed, like it was just like a tube basically within the VAD. So it was interesting. It literally didn't move. It was like 1.44, 1.46, 1.44. So I thought it was pretty. Like I agree with what Rohit said. It did. It was dynamic, and especially until 2 days prior, and then it just got fixed. I kind of want to make a comment because I see Amy is here from internal medicine. Again, we're going to pick on internal medicine today. As many, I don't know if you guys know, but many of our patients, especially when they're 1 year after VAD implant, might be admitted by the hospitalist service. So I would say, if somebody, like Rohit said, has an LVAD, was doing well, and then now is in a heart failure, I think that kind of, on our part, warrants really quick evaluation, and on the hospitalist part as well, kind of alerting us. And again, we don't want to change our practice based on 3 out of 30,000 cases, but that was interesting. It did happen to us, so. I know Carly would like to maybe comment because she really was, ultimately, she was the hero,
I don't know about that. I think
Do you want to just talk about it a little bit?
So nice presentation, Rohit. As mentioned, this is unbelievably rare. I think really it highlights the teamwork that night of the cardiology folks in Kasha really taking expedited steps to figure out what was going on, given how progressively sick he was getting. We put him on actually awake via ECMO, Anil did, in the operating room first because we were worried given the degree of pulmonary hypertension and instability he had developed about how he would behave during induction and just not being able to adequately support him, and he tolerated that very well. We did this through left thoracotomy, pump exchange, converted his ECMO to bypass and did the pump exchange. Dr. Oliveras helped with that also. And he did incredibly well. He was like home in 6 days. But I think it was a really interesting sort of process for all of us to learn how this came about and then get the analysis from the Abbott people. And really, we had anticipated this would be thrombus, and turns out it wasn't. And so I think the question on all of our minds is, well, now what? And we don't have an answer for that yet either, but, super interesting. And really, I think our team saved this man's life, so, yeah.
Just to piggyback on Dr. Renovic's comments, like you were saying, if you suspect this, what really clued us into this is, I still remember it was post-call and overnight I admitted this patient, and we were walking to the Commons and really wondering what's going on. And what clued us into this or made us a little suspicious of it was really the increase in the LV size. So, just to put that in perspective, in March he had an LV size of about 4.6 centimeters, and now he comes in with 7.1. So that kind of clues you into something is wrong with the LVAD, where there's obstruction of flow and there's not enough LV unloading. So whether it's the LVAD itself or the outflow graft or the inflow cannula in our case, it just warrant further evaluation.
And I would say troponin saved us because Rohit was driving me crazy because he kept checking the troponin. And I was like, why are you checking the troponin? And he was right, because actually he had an STEMI because he wasn't literally, getting no perfusion to the coronaries, which was interesting. The other thing was back to Mike's comment, and I don't know if ECHO compared it, but that is also something that for us is a very important piece of information when you're reading an ECHO to compare. If LVDD increased, we want to know about it. But I think troponin saved us and your persistence, Rohit. So.
Yeah, if it's trending up, it's hard to not recheck it again. Until you have an answer. But I just want to finish off with Dr. Lodovic. It's not to put you on the spot, but or any of the surgeons really, if you can comment on a little bit about, why. I know we kind of talked about it a little bit about why, as in a certain patient, and I kind of touched upon this a little bit. Maybe you can do it a little bit of detail about why one would choose to, oversew an aortic valve versus replace it or repair it.
Yeah, so good question. I think there's probably a lot of factors that go into that. So when we talk about oversewing, sort of quote unquote, it's the Park stitch. So the valve is not theoretically completely sewn shut or closed shut. You basically bring together the nodules of Aranti of the leaflets in the center. So the valve can't completely open or close, but theoretically there is blood that can pass between the space in the commissures, I guess, of the leaflets. So I think that's probably the most common method for oversewing, and versus biologically replacing the valve. I think really the biggest advantage, as Rohit mentioned, to oversewing is the cross-clamp time. I mean, you can do it in 10 minutes. And this is something in patients, especially that have bad RVs, we're trying to minimize the cross-clamp time on the rest heart. Then it's a lot sort of faster and easier than doing a whole AVR, which takes about an hour usually. And thinking about who your patient is, if they're a little bit older, obviously, if you think they might recover, oversewing the valve is not a good idea. And then there's also variability in patients that get bioprosthetics in how long they last and how well they function and complications related to that. So I think there's no perfect solution. Was this a complication whereas hemodynamics were made worse because his aortic valve was closed? Probably. But will it change my practice going forwards? Not necessarily. I mean, I think, before we do these operations in patients with AI that need intervention, there's a lot of things we take into consideration. So, yeah.
Awesome. Thank you so much.